few people have mentioned already, kidney sparing approaches, right? And the current treatment we have and what that looks like going forward, right? And I don't think, we've been talking about these endoscopic ablations. I don't think the concept of trying to spare people's organs is a brand new concept, right? I think that we have done that in many diseases that we do as in urology and in GU, we've done it for upper tract as well, but we might have newer things. And of course, as technologies and everything starts coming out, we get better and better. So when somebody says kidney sparing, what does that mean to you for upper tract urothelial?
To me, it means endoscopic management, trying to avoid nephrourectomy as much as possible.
Yes, so there's patients who are amenable to kidney sparing, actually spanning the whole spectrum of upper tract urothelial cancer, right? So, even though there are risk stratification category, we also talk about patient factor, and we can be so dogmatic about, the disease process without taking into the patient factor. So when, patients who are amenable to kidney sparing endoscopic ablations are patients with definitely the left side of the spectrum, the favorable low risk patients, and sometimes the unfavorable low risk patient, that you can definitely do kidney sparing. If you can treat them completely with laser ablation, that would be ideal. In cases where you cannot reach the tumor, which often can be the case, then there are intracavitary therapy that we can give them. And then on the other side of the spectrum, where the high risk disease is, you talk about patients who have competing risk factors, who may not be able to tolerate chemotherapy, or who's not able to tolerate a surgery without putting them at risk of dialysis, which we know, increase their mortality rate, sometimes even higher than the risk of upper tract cancer itself. And so in some of those patients, we can go off the guideline a little bit and talk about, kidney sparing approach for that reason.
Yeah, I will make one comment, and we do a lot of organ sparing and preservation, and it's an important part of our treatment options. But we also want to think about when patients go on this path of ureteroscopy and endoscopic management, especially with Jelmyto and repeat ureteroscopy, it's a lot. And it is a lot, and I think it's really important, especially in the elderly, to think about the potential side effects of repeated anesthetic episodes on cognitive function. And so I think of a patient of mine who is in her late 80s and has totally normal other kidney, had high volume, low grade disease, and we went through those options, and we actually went for a nephrourectomy because it was a one event. Did not require multiple anesthetic events, and she flew right through, and she's done. And so those are important things, I think, to think about when you're managing these patients.
Yeah, I think you're right. It's important to lay that out for patients, right? That the diligence that's required to do repetitive ablations, and that being mechanical ablations with a laser, along with chemo ablations and adjunct therapies with mitomycin gel and anything else that you could use, you must be diligent. You've got to be looking in those kidneys often. You have to be doing that. And so a patient has to be, ready for that and know what that looks like. And when you have imperative indications, meaning the person only has, that's their only kidney, or they have, a terrible kidney function that removing one is going to put them on dialysis, it makes that fairly easy, right? And they say, okay, I don't mind having a ureteroscopy every 3 months. But when it's not, it is an important thing to weigh out. So, something interesting, we're having this conversation as urologists here, and then we have our medical oncologist here, and so he doesn't deal with directly a lot of low-grade disease, but I actually am going to talk about, we recently had where he's actually become very involved in our practice with treating patients with low-grade upper tract disease and helping us administer through the cancer center some of our mitomycin gel therapy. So I was just curious if you had any comments now that you're seeing some of these patients along with us, Scott, after we do these ureteroscopies.
So yes, it's been exciting and certainly I've been learning a lot, taking over some of the treatment with the gel mito over at NYU. I've obviously, we want organ sparing. That's what we always strive for. So I think in low grade, getting gel mito as an option is extremely important. And I'm gonna, although this is an uncommon cancer, and I'm gonna talk about a very niche part of upper tract, but I feel like if I don't get my medical oncologist science out, I will explode. So I mean, we were talking about a small percent is going to be MSI high and microsatellite stable. And while I don't think this is in any guideline, or I wouldn't do this as a standard of care, I do think where the puck is moving is at some point we're going to see these patients and we're going to try to use something like an immune checkpoint PD-1, PD-L1 blockade for organ sparing. Because looking at the rectal literature, I mean, there's patients that have been saved from surgery in that exact situation with like 100% response rate. So I think, yeah, go ahead.
Yeah, and just, I mean, on that comment, I mean, Pembro is FDA approved.
Yes.
For, you know, any,
MSI high, yeah.
Exactly. So, and, you know, I've seen some cases presented at our course yesterday, you know, at MD Anderson. There's some really impressive cases. And so, yeah.
Yeah. And I think at some point we're going to be looking at those and maybe looking at Pembro as an option for organ sparing.
Yeah.
Yeah, there are ongoing clinical trials for that, and you know, as an extension of the rectal cancer trial that was published in the New England Journal of Medicine, they also enrolling patients with MSI high DDR MMR deficient tumor for upper tract cancer, and you know, speaking with some of the investigator, the response have been very profound, and that's why the AUA guideline implement the universal tumor testing, because it does impact patients in their treatment, not just, you know, family counseling and cancer surveillance. These really do impact patient care.
Yeah, I think the other thing to keep in mind with, especially since we're on the subject of low-grade upper tract urothelial carcinoma, is that upper tract disease is one that, you know, sort of, as my medical oncology colleague likes to say, notoriously doesn't play by the rules always. And so you have to be careful. And I you know, had to have a patient with bilateral low-grade disease, by all accounts endoscopically looked low-grade, fluffy papillary, looked absolutely perfect. Did gel mito, both sides, great response. She remained disease-free. And maybe 18 months later, there was a little nodule that was being followed, lung nodule, and it was metastatic urothelial cancer. So you have to really be, and I never ever predicted anything was high grade based on how everything looked and biopsies and everything and cytologies. You just have to be careful.